So we'll start the program. So good evening all dear viewers. This is our 37th peculiar case series renal transplant meet. And it has been going uninterruptedly for the past 3 years. We are stepping into the 4th year. And this 4th year is no longer, this is also, it's not a routine affair. Actually, we have as usual, we used to have 2 cases for discussion. This time we take up 1 case actually, and we to have a deliberate lecture discussion on this case. So basically it is like a benign cyst actually. Yes, cyst always not benign, and even the donor cyst, even though it looks benign, many studies have shown that the cyst in kidneys has potential for giving a hypertension or reduced GFR in the donors in the due course of time. And many studies have shown it is always benign. So this session, probably this presentation followed by a discussion will unravel many mysteries, and we'll get a consensus on how to evaluate the incidental lesion in a kidney, whether a cyst or a solid lesion. So we can have a consensus at the end of this meeting, because it is very common scenario, and you'll have a when you work up a donor, you'll have find a cyst in a kidney or in a non-donated kidney or a retrieval kidney also. So many people were skeptical whether to take the kidney or not. So this is going to give a true insight into what has to be done. And to make this journey interesting, and Dr. Swarnalatha madam is it is the right person to unravel this mystery. Actually, she's from NIMS Hyderabad, and this crowd know her better than any other crowd. And she's a voracious academician, and he's heading a cadaver transplant program in Andhra Pradesh. She's an additional professor of NIMS Hyderabad. And ma'am has been kind enough to be in our forum. Actually, she has presented twice. She has been a panelist for 2 or 3 occasions, and it has been a very good relation with her, which keeps our peculiar case series on a move. And her junior consultant, Dr. Vijay Chander, will be presenting the case. Madam will be chipping in with her insights and her comments. Joining this session are the 3 eminent panelists. I am very much happy and privileged to welcome Dr. Deepak S Ray, and he's a kingpin of nephrology and transplant in India, and he's running a transplant mill in eastern part of India. And when I went there in 2017, and he's the one who is instrumental in making me to start the program, ABO transplant program in this part of the place in Tiruchirappalli, where we have completed almost 35 ABO and compatible transplant. How to do an economically viable ABO transplant. That is very important thing that he taught us. And he has been a true master of the nuances of renal transplant, particularly ABO transplant. And his titer almost, we were discussing about the titers, and he was telling that I used to keep the baseline titer, now it's 1:64, which is unimaginable for me actually. So such kind of experimentations and everything he does in transplants, and he is the right person here to give us insights and comments regarding how to evaluate the renal cyst. Actually, he's a director and chief nephrologist at Narayana Health, Calcutta. Before it was called as Rabindranath Tagore. It's like a big government hospital. It's not like a private hospital. It's like a big government hospital where you find a lot of crowd, actually, unimaginable crowd. I was astonished to see that hospital and all. So thank you. Welcome, sir, for this meet. And joining him is Dr. Ilangovan Veerappan. He's one of my friend, and he's a chief nephrologist from KG Hospital, Coimbatore. He's always known for his academics, and his precise decision making and precise talk, and even his comments and peculiar case series WhatsApp groups also are well appreciated by the eminent nephrologist. And he's a product of CMC Vellore, and he has many transplant, particularly ABO transplant industry's credit. And he's a DNB trainer, and he's a peer reviewer of many journals, and has presented various papers. And I'm very happy to welcome Dr. Ilangovan Veerappan to this meet. And Dr. R.Sakthirajan, not last but not the least, he's always a kingpin and backbone of nephrology in Madras Medical College. And he has been true lieutenant to Professor N.G. Kesar, and making this institution one of the top academic institutions in India. and he's a very good academician. And the reason behind calling him for this session, they do have a case. They do had a case of incidental renal lesions in a donor, and I think his inputs to this forum will give us a lot of meaning into that talk, which Madam is going to deliver. And without wasting much of the time, and I will invite Dr. Swarnalatha Madam and his team, Dr. Arun Chander, to start his presentation.
Thank you, Dr. Rajarajan. So before diving deep into the subject, I would like to express my heartfelt appreciation to the team, because Dr. Vel and Dr. Rajan, I still remember the initial programs when you called me during the COVID times. I thought it would be, it's just a platform for the COVID, the virtual platform for the COVID. So many programs or platforms have come, but they were only for the COVID. But I think this is one of the platform which has survived the COVID, not only the COVID period, but after that also you can see successfully running. And this being the 37th, the 4th year entered. And I wish it will continue like this and remain, and shortly you will try to touch the 100th century also. And I wish you for this successful academic program. Not only this, I also see that you have this very dedicated scientific WhatsApp group where very active discussion. So I find this one of the the group which is focused to the scientific discussion. So that is also really appreciable, and really congratulate you for successfully running two scientific platforms for all of us to learn about the transplantation. So coming to the today's topic. Yes, and I really appreciate every time you come up with a different concepts, and it's very heartening to learn through the experts. You bring all the experts into the platform, and it's very welcoming that we learn from the experts and their experience, and we also try to update and whatever the literature is being published in the journals. So and the guidelines. So really thankful to you. So coming to the topic now, I think the evaluation of the cyst in the kidney donors. So it is not uncommon. I don't say it is common. It is not very uncommon. There have been evolving literature as transplant physicians. We know that we struggle to expand the donor pool and try to narrow the bridge. I mean, we have expert here with respect to incompatible transplantation. We have the kidney pair donation, and we are also trying to explore the expanded criteria donors, including the kidney cyst in the donor. So it has been said that simple cyst can be taken as a donor, and we have the literature where ADPKD with a high risk of the being transplanted, high risk of in the donors, and they are contraindicated. But however, it has also been said that simple cysts are no more simple, and at the same time we have anecdotal case reports where the ADPKD donor, particularly with respect to the deceased donor, have been taken successfully with respect to basically we added the two case reports where the deceased donor, the ADPKD, the young donor without much increase in the kidney sizes of less than 15 centimeters, and the recipient age being more than 65 years, they have been successfully transplanted. So of course, there is a evolving literature, and I think this is an apt topic to discuss and learn about what are the various risks and recommendation associated with cyst in the kidney donor. And we had a very interesting case recently we have come across, and we were struggling whether to take or not to take. And another interesting part was he's the husband. I mean, all our experiences, I'm sure, the husband coming forward for organ donations, it's a very rare phenomena. We have done around 1,700 transplantations so far, and we could see only single digit this husband being the donor. So this husband was so motivated. The recipient was ADPKD with a very strong family history. Two sisters were affected with ADPKD, and the problem is they had a consanguinity. And during evaluation, we found to have a cyst in the donor, and her husband was very much motivated. He said, at any cost, I have to donate. So we were looking at forward what are the recommendations and what are the guidelines, and whether we can take it or whether we had to discard this donor. So in that context, we have very interesting case, and I request our junior faculty, Dr. Vijay. He has worked up the case. So that's why I wanted him to present how we have evolved, in evaluating this patient. I don't want to reveal the other part, other details of the case. I would request Dr. Vijay to, discuss in detail about the case and followed by the recommendation. After that, we anyhow will listen to the experts in the panel discussion. Over to Vijay.
Thank you, ma'am. Thank you for the. First of all, thank you for the opportunity. I thank Swarna ma'am and also the organizers of Peculiar Transplant Case Series Group for giving me the opportunity to present. I hope my slides are visible.
Yeah. Make it as a full screen.
Yeah.
Okay.
So, evaluating renal cysts in potential kidney donors with a positive family history. We recently came across one of the donor, as madam has already told about she has given the summary, short summary, that is very much motivated to donate to his wife, who is a ESRD, CKD ESRD, 5ND. Without much delay, I'm going into the case details. The recipient is a 44-year-old female. She is diagnosed to have cystic kidney disease in 2010 when she had loin pain. That time she was evaluated outside and there was a small stone of less than around 5 to 6 mm in one of the poles. She was managed conservatively. That time the imaging had showed that she had cystic kidneys and her renal functions and blood reports were normal, and also there was CU being bland. There were no reports. This was only written in one of the case files, and she was managed conservatively. She was asymptomatic for 8 years, but she says she had regularly done her blood and urine tests and renal functions being normal. In 2018, she had hypertension and was started, and the outside practitioners have started around 2 antihypertensives. In 2020, on routine evaluation, her creatinine was around 2.1, HB being 10. CU was again bland, 1 place albumin, nil RBC and 1 to 2 pus cells. And she was started on routine CKD management. First time she has come to us in the month of May this year, presented with nausea, anorexia, and all the uremic symptoms. Her creatinine was 6.5, GFR being 7.5 ml. Then we have started, I've advised her to start her on hemodialysis, but she wasn't willing. And the husband was very much motivated to donate. This is a family history. Sorry. This is a family history. This is a patient. I hope you can see. 1 second. Yeah, this 44-year-old female is a patient, and they have done when 47-year-old is a husband, and he has 3rd degree consanguineous marriage. They had 3rd degree consanguineous marriage, and the first child, male child, died at the age of 35 years with some congenital heart disease. There were no reports available, but if you see her side, her elder sister also is a case of CKD, ESRD. She's on dialysis, and her eldest sister died at the age of 30 during as one of the complications during dialysis. They told it as some arrhythmias during the time of dialysis, but there were no reports. And the mother of this patient, 44-year-old patient, also is a CKD ESRD patient, also died in hemodialysis. There's a strong family history on her side, and the donor, who is the husband, is 3rd degree consanguineous. You can see here the father of the donor and the mother of the recipient, both are brother and sisters. So coming to the recipient investigations, she's A positive blood group. At the time of admission to NIMS, she had a hemoglobin of around 8.8, RFT being creatinine of 6.5 and potassium being normal, 4.5. LFT is normal. CUS stated here, it is normal. PCR is around 0.56 and PTH of around 165, MCUG being normal. Ultrasound reports had shown that the right kidney is around 22 centimeters and left kidney is around 16 centimeters. Multiple parenchymal cysts are noted. liver cysts are also noted. So with this, we had taken the opinion of our genetic team. The patient sisters actually had whole exome sequencing done. Patient elder sister who is currently on dialysis also had ADPKD. So her mutation actually showed a PKD1 mutation in the in the PKD1 gene mutation in the exon 15 here, and it was likely pathogenic. And coming to the donor details, donor being 47-year-old male, he's a goldsmith by occupation. He doesn't have any comorbidities. There are no addictions. Vitally normal when he's presented to us. And his investigations A positive, so blood group matched, and CBP is 15.5 HB, 7,200 WBC counts and 2.7 lakh platelets. Creatinine is 0.62, CUE is normal, nil albumin, nil RBC, and 1 to 2 pus cells. 180 milligram per liter of 3 liters of 24-hour urine protein. His OGTT being normal, HbA1c also being normal, and DTP urinogram. You can see here the right kidney showed around 60.1 ml of GFR, and left kidney is having 55.8. Roughly, it is 115 completely. IVP being normal. His ultrasound report is actually normal except for the fatty liver, grade 1 fatty liver. You can see the kidney size being 11.1 and 11.6. There are no cysts visualized. So we went ahead and we further worked up, because the donor renal angio actually has been done to see the number of arteries and veins. But during the donor renal donor CT angio, we could see that there are two cortical cysts which are subcentimetric, and left one cortical cyst. So we had actually done a Sanger sequencing after taking the opinion of our genetics department. But you can see that exon 15 PKD1 mutation, which is there in our sister, was not present in this patient. It is absent. But because the CT was showing subcentimetric cysts, and there's a strong family history, we have also asked for whole exome sequencing. Before I could post the report of whole exome sequencing, I'm trying to show here the cyst here, noted here in the left side, and a small subcentimetric cyst here in the right side. And his MRI was also showing 2 to 3 subcentimetric cysts in both the kidneys. Now, when I have actually called up the radiologist to ask exact number of cysts, they confirmed it that it has 3 cysts in each kidney, 6 cysts in total. So the whole exome sequencing report actually again showed a PKD1 mutation, but a different exon site. That was exon 15 in the recipient's sister. And this donor actually had a mutation in exon 21, but this was uncertain significance. Now, we were not sure what to do, because he has cysts, roughly 6 in number in MRI, but creatinine being normal, ultrasound being normal, his age being 47. And there is a strong family history of polycystic kidney disease, and most of them are on dialysis too. And whether I should take this report as significant or not, we were not knowing. So we have asked even the donor's father, who is asymptomatic, completely asymptomatic. He is aged 70 years. His RFT and CUE were normal. His MRI showed multiple bilateral cortical cysts, more than 10 cysts in each kidney. This is what the radiologist has told me. So this is regarding that case. The questions in this case were, why is the disease not manifesting in donor's father at the age of 70 years, despite having roughly 20 cysts? What is the ultrasound diagnostic criteria for ADPKD, and also to rule out ADPKD? I am more concerned at the age, with the age of 47, because donor is 47 and 70 years being the donor's father age. And MRI diagnostic criteria, if at all the literature shows anything. And which modality is best, whether CT or MRI in diagnosing ADPKD. And can ADPKD donors be taken up for kidney donation? These are the questions which I'll be answering subsequent literature search. So this is regarding the first question. Why is the disease not manifesting in donor's father? This is a dosage model of cystogenesis in ADPKD. You can see here that the healthy kidney, despite having PKD1 alleles here, the functional polycystin C, which is most important, if it expresses 100%, then there is no manifestation. But if the PKD1 mutation is at R3277C site, 75% of the functional polycystins are expressed, and they may be having only few cysts. And in the similar way, there are some other mutations stated in the literature that it can be as lethal, like in the embryonic stage only, or it can even manifest in utero also. So based on the expressibility of these functional polycystins, we'll be knowing that whether the patient will be manifesting earlier or late. This would have explained one of the reasons why patient was not, especially the donor's father, who is 70 years, despite having 26, has not manifested. This is what we thought of, but we are not sure. Excuse me. Right. Are my slides moving?
No, your slides are not moving.
Look at the dosage.
Okay. So this article is taken from Nature's Reviews. Yeah. And now coming to the diagnostic criteria, this is a unified criteria, very well known to us. You can see between the age of 40 to 59 here. 40 to 59 here. That more than 2 cysts in each kidney are enough for confirmation of ADPKD, but to exclude between the age of 40 to 59, there should be no kidney cysts. This is an ultrasound criteria. So, but in our donor, they were not present, the ultrasound being normal. And this is taken from AJKD core curriculum. Kidney cysts with the family history of ADPKD. We have a genotype which is known, and it is a PKD1 gene. And if we follow this age 30 to 59 years, more than or equal to 2 cysts in each kidney on ultrasound, then it will be diagnostic. The unequivocal results are there. But if there are equivocal results, like in our patient, the ultrasound actually did not show anything, any cyst. But the important point being here, in patients less than 40 years with PKD or with PKD2 or with unknown genotype, MRI of less than 5 cysts excludes ADPKD. Our donor actually had aged 47, and his MRI actually showed 6 cysts. So we were not exactly sure. With the literature, there is no literature beyond 40 years which can tell exactly how many number of cysts are required to rule in or rule out ADPKD. This is what I want to highlight here, and this is taken from AJKD core curriculum. So this is one of the article from Jason. The one which is highlighted here, a total of more than 10 cysts as a test criteria in subjects younger than 30 years of age. We found that MRI provided both a sensitivity and specificity of 100%. And similar results were obtained in test subjects between the age of 30 to 40 years. So with this article, we can definitely say that less than 40, we have a good MRI diagnostic criteria to rule in ADPKD and also to rule out, as I said earlier. But beyond 40 years, what is the MRI criteria? No one has, till now, the literature is scanty. And these are some of the recommendations, American Society of Transplantation, that states that a potential donor at risk for ADPKD should have an ultrasound early in the evaluation so that we can rule out and we can find out alternate donors. If the ultrasound is equivocal or the patient is aged between 18 to 30 years of age, either genetic testing or an MRI may be used to rule out PKD. So they have stressed upon the MRI, not the CT here. And genetic test is only useful in screening donors when the mutation is affected and the affected family member is successfully identified. And KDIGO 2015 emphasizes the utility of MRI fewer than 5 cysts on MRI will rule out PKD in the potential donor. And these criteria are for MRI and are not as yet translatable to CT. This is what the AST recommendation says, that MRI is more sensitive, and that too, age less than 40, we can rule it out. But beyond 40 years, the literature is scanty. These are the recommendations from Spanish Society of Nephrology. If there is no family history of polycystic disease, isolated small cysts, there is no obstacle. And some hospitals have even taken up to 4 cysts, provided ADPKD is ruled out or there is no PKD1 gene mutation. And finally, coming to our 2017 donor evaluation KDIGO guidelines, it strongly states that donor candidates with ADPKD should not donate living kidney donors, and donor candidates with the family history of ADPKD in a first degree relative may be acceptable for donation if the age specific imaging or genetic testing criteria rules out or excludes ADPKD. 40 years or older with a first degree relative with ADPKD, single cyst or no cyst reliably rules out ADPKD. This was actually KDIGO says, and this is the ultrasound criteria which they were talking about. However, the utility of ultrasound to rule out ADPKD in younger donor candidates is more limited, where an absent or limited number of cysts on CT or MRI can be considered to rule out ADPKD. 2017 KDIGO guidelines says that CT or MRI can be substitutable, but AST guidelines strongly recommend on MRI. So these are a few indications which everyone are aware of in genetic testing for ADPKD. Whenever we want to take a relative who is actually has a ADPKD in a family with the family history, and imaging as actually rules out the ADPKD by no cysts, then we can, or if the imaging is not indicative or imaging is not actually suggestive of ADPKD, then we can bring in genetic testing. And in individuals with negative family history, to establish a firm diagnosis or to test for mosaicism, genetic testing has been done. And in cases of polycystic kidney disease of unknown origin or negative family history, to assess the recurrence risk and for family planning. In patients with very early onset of disease, then to identify biallelic disease or other complex genetics. These are some of the indications. I don't want to go through completely, coming to the outcomes of renal transplants from donors with polycystic kidney disease. As KDIGO 2017 says, the living kidney donor should not donate, but it hasn't told anything about the cadavers. These are actually a compilation from different case reports by Shamali et al. 16 cases were identified. Their median age was around 24 years and the recipient age was 46. And 15 had a single kidney transplant and 1 had a dual kidney transplant. 13 out of 16 patients had immediate functions. 2 patients had delayed graft function and 1 patient had primary non-function. And their median graft follow-up was around 36 months. Median serum creatinine at last follow-up was 124 micromoles per liter. This roughly comes out to be 1.4 milligram per deciliter. The range being 75 to 442, 442 being creatinine of 5. So 13 patients were still alive with a working renal transplant at last follow-up. This gives some hope that even a cadaveric ADPKD kidneys can be transplanted and they do well, so that we can expand the donor pool. And this is our own data, unused diseased donor kidneys. Roughly from 2020, when I could track the data, 10 were having cysts. Of them, 6 were used, 6 donors were used. These 4 were not used. The summary is provided in this table. The first candidate donor had a 31-year male and had a death due to IC bleed. His BMI roughly is around 24-25, and he is non-diabetic and he's hypertensive of 5 years duration. His creatinine at the time of presentation was 3. And you can see the ultrasound report here, 14 centimeters and 12 centimeters of kidney, and multiple anechoic cysts are there in both the kidneys. And they haven't done a biopsy here. The reason for discard was in view of bulky kidneys and multiple cysts, thin node parenchyma and high creatinine. This was the reason mentioned in the portal. They have to upload the reason also in the portal why they haven't used the kidney. So that is the reason why they haven't used this first kidney. Second donor being 57-year-old female. died again due to RTA, and she had a kidney size of around 12 and 12.7, and she had liver cysts and kidney cysts too. It was by classical polycystic kidney disease, so they have rejected this. Third one had a 54. Third one is a donor is a 54-year-old male who had left the capsular ganglionic bleed, and he had a kidney size of around 9.6 and 9.7, and then they have gone ahead with the biopsy. The MAPI score was 15. That was the reason why it was rejected, and he also had a few cysts, which were not actually mentioned here, but he also had few cysts. And there are fourth candidate was 60-year female, died due to RTA, and she had 12.6 centimeters left kidney and 13 centimeters right kidney, and there were non-enhancing thin cortical cysts. This is CT scan finding noted in both the kidneys, and 2 being in each kidney. Largest one is around 2.6 centimeters, and it was in the left kidney. The frozen biopsy report is absolutely normal. There were no glomeruli, but there is no tubular atrophy seen. Interstitium and vessels are also normal. This is a kidney which has with the cyst which has been rejected. The parenchyma is thinned out here, and by this I would like to conclude that even donors with ADPKD, especially the cadaver donors, we can take the kidneys, given that the article actually states that the median follow-up is actually they are doing good, at least in the medium term. And with this, I'd like to thank the organizers.
Thank you, Vijay, for discussing the case in detail. So these are the challenges. Here we have a donor and the recipient pair with a very consanguinity, with a very strong history of the ADPKD in the recipient side. If you look at the chart, the pedigree chart which Vijay has projected, so both the sisters and mother of the recipient had ADPKD, and they have died on dialysis. That was the reason why the patient was not interested in going for dialysis, and she wanted to have a preemptive transplantation. And now the very first, when the husband had come forward, we were very happy. And because though they were consanguinity, the husband side, the donor side, there was no family, none of the member of the family member affected. So we thought that, but we thought that only the recipient side there is no ADPKD probably gene is there, and the donor side probably it's not there because there is no obvious family member being affected. So we went ahead, and even the ultrasound showed there was no cyst. So, but the cysts were seen only in the angio, when the renal angio. So that made us to go for a ultrasound abdomen, the MRI and the genetic testing. So MRI also, it was equivocal, because if MRI more than 10 cysts in each kidney, it is the confirmatory of ADPKD, and we should avoid such a donor. But here we had 2 to 3 cysts in each kidney. Again, less than 5 can rule out. We had a cyst between 5 to 10 cysts. So this was again little when there was a dilemma. So then we have asked for, because we had the sister already had this the genetic testing done, and in the recipient we had only because we didn't go for the genetic testing of the recipient, because the family already had that the gene testing done. So that's why we already asked for the Sanger sequencing of the exome 15, which was identified in the sister of the recipient. So when initially it was negative, we were like little happy that we can still go ahead, but we were little not very certain whether we can go ahead, because number of cysts, the age, and somehow the donors. We also got this. Whole genome. Done exome sequencing done. Unfortunately, it identified another defect that was in exome 21, and they said it is not of significance. So we were little confused whether to go ahead and not to go ahead. And then meanwhile, because of their enthusiasm, they got the screening test for all the donor side also, including their own father. And surprisingly, father also found to have father of the donor was found to have the cyst. That was at the age of 70. It was almost more than 20 cysts in each kidney. So now, we have not yet transplanted this patient. We have just recently finished. That's the reason why the moment Rajarajan called me, I said, PK, we will present this patient and we will seek the opinion of all the expert. With this background, whether can we proceed with this transplantation? And what do the literature say? And are we legally protected? If at all something goes wrong, and are we legally protected to justify ourselves in doing this transplantation? So I request, the panelist, I hand over to the panelist and then, suggest us and then, come up with a certain consensus so that we can proceed with this. Over
Thank
to
you, Madam Susan. Thank you, Madam. It's a good, thoughtful, and insightful presentation, and I think it evokes a lot of response from the panelists and the audience. And Dr. D.S. Ray, your comments, please.
Yeah, I think very simple. Whenever we find a cyst in a donor, nowadays we are getting more because we are using CT for angiogram and all that. Not you can miss in the ultrasound, you don't miss in CT. So two things we need to think about. One is whether the donor has a PKD. 20-25% patients may not have, or donors may not have a family history because of several reasons. So, or there is a malignancy. These two are important things we look for. So if it is malignancy, you know that Bosniak 3, 4, we will exclude and all that. In this patient, since the ultrasound didn't show and he is 44, above 30, normally the classical teaching, if the ultrasound doesn't show cyst, then 100% probably he doesn't have a PKD. The cyst MRI can detect more cyst, and MRI, in fact, to diagnose PKD, as mom said, should have 10 cysts at least in one side and around similar number in the other side, or hepatic cyst and pancreatic cyst, etc. So imaging wise, it doesn't look like a PKD. At the same time, and whenever there is a doubt, one need to do a genetic test, and rightly it was done. And since it is also negative, I think one can go ahead and do the transplant.
Now, genetic test showed it's not the exon.
I understand, ma'am.
It was there with the recipient. It showed another, genetic, exon 20 or 21 or something like that. So because again, genetic test, we cannot rely on what is the existing literature, because all this literature has evolved from the Western literature. Now, because every 6 months it's updated, depending upon what literature is evolving. So after 6 months, if they say that this whatever the genetic defect, the exome 21 which donor had, it can be put it as a pathogenic variant. So then we are legally answerable. So because end of the day we should know clinically. Initially when we were evaluating the donor, because ultrasound didn't pick up any cyst, we never thought about the ADPKD in the donor. We actually went ahead and in fact the renal angio was also done. But subsequently, when donor have been high risk, in fact, one of the articles says high risk, any cyst, you should rule out. You should, think it is a potential.
That is controversial, madam. There are articles also not supporting that, and that the cyst can have increased proteinuria and hypertension. So that's normally we do use if there is a single simple cyst and you don't think of PKD, there is no family history, and if there is bilateral and all that, you do a genetic test also to negate that. Then you can go ahead and do that. Normally you have done, and not very few, simple cysts are not very uncommon. They are reasonably common probably, and they don't have problem. Our follow-up doesn't show much a problem. But this is a different situation, and see his father having cyst at 70s, beyond 70, you can have multiple cysts and all that. And these are all MRI findings. These are not ultrasound findings. Ultrasound findings will miss this cyst, and MRI can have more number of cysts. That's why the 10 cyst criteria has been given. So to me, it looks like it's fine if you go ahead. And you have to go ahead with the present literature available, not future, whatever change comes that will be incorporated later on.
Okay.
I agree
Dr.
with this.
Ilangovan? Yeah, thanks.
Yeah, thanks.
Go ahead, madam.
Swarnalatha madam, and thank you, Vijay, and also the case Rajarajan and S.Vel Arvind for bringing this up. I think it's something like very common, and I'll tell you like my take. We are no longer the panelists. Looks like we are jury here. So the first thing is, forget the genetic test. If you use the simple logic of pretest probability of cysts being high in this family, and you find any cyst of more than like 10 cumulatively in both the kidney, without a genetic test, this will be branded as ADPKD. And so if you use statistics, this is ADPKD. And I cannot explain as to why the PKD1 different gene came up here. So that's like, I would like leave it to the experts into that field. But to me, this is an ADPKD. And I also want to point out here, like there is some discordance between ultrasound, CT, MRI. The problem with CT is it is highly, it can be affected by the perirenal fat. Obesity can affect the pickup rate of renal cysts, especially if the cysts are going to be subcentric. That is the reason people always vote towards MRI for counting the number of cysts accurately. So if you have a very thin individual with very less fat, both MRI and CT will be almost the same. But like the more obesity comes, you are supposed to change the voltage that is delivered and also few other technical parameters, which generally most hospitals, most technicians, most doctors would not do. That is the reason for the discordant number counting of CT and MRI. So there will be some case where everything matches and there will be some case where it does not match up. So I think that question of which is good, I think MRI is definitely far better. But if you ask me, like, if I was the doctor here in this case, I would go ahead with the surgery. But this is definitely ADPKD for sure. This is ADPKD. The reason why I would go ahead is like the patient has lived 47 years without having a kidney ailment, and also his own father is also living without a problem, and then you don't have a donor in the pool who can donate in the place of the husband. So with a high risk consent having declared very clearly this is definitely ADPKD, and definitely there's a very small theoretical risk of end stage, and if he survives like say 90 years, he may become a patient himself. It's all question of how long he's going to. So in a statistical point of view, considering the likelihood ratio, pretest probability, all those things, if you put it into the equation, this is definitely in ADPKD.
So it is interesting that we have two different comments between the panelists. And let me invite Dr. S.Sakthirajan.
I have a doubt, sir. Actually, does after transplantation, does the hemodynamic stress doesn't increase the chance of ESRD in the donor also? Now I would be ending up both of them into ESRD. Does it happen? Because ADPKD, we are already sure that there are 70-year-old grandfather has many cysts, and also he also has around roughly 6 cysts. And post transplantation, if the hemodynamic stress doesn't push to ESRD, that is what my concern was. We were actually denying, we were saying him that we cannot do because of that reason, because the filtration fraction may go up and all that. And that time, if they precipitate any secondary FSGS and that, and that I was explaining to him that we may not go ahead.
I don't know anybody. I mean, unless you have data for that to power against it, it would be difficult to say. And even in some of the cases where you rejected, even a normal size kidney did have a lot of IFTA there. That's what you showed in one of the frozen section. And so it's difficult to answer that question, like what happens when you have a single kidney. I really don't know how do we do with that, but the premise with which I'm saying is he's already close to 50. The donor is close to 50, and he's got an almost normal kidney function. So even if 2% decline in kidney function becomes 5%, I think still some more years to go. That's what I would say. But then still there is theoretically chance that it will worsen, and so you need to take all these factors and make a call.
So actually, I agree with you. In fact, that was a discussion, argument going between me and Dr. Vijay. So he says, we have to, withhold this. And as you said, it could be, we cannot completely rule out this because we have the cyst now. He comes under high risk with a very strong family history. And the number of cysts are just arbitrary, something like a bottom line guidance for us. So any cyst demonstrated with a strong family history, I think it will turn out to be an ADPKD, and though there is a different genetic variant. So, but having said that, as you said, there is a paradigm shift. Now we talk about the expanding the donor pool and taking the patient even with diabetes. Previously, I mean, diabetes was absolute no. Now we take even diabetes, particularly in fact, if I remember one of the talk by Dr. Dogridas, he said, rather than having a young standard criteria, is always better to go for a patient who are elderly with external criteria, because already he has lived the life. And we know the natural history, and even with cyst, this cyst would have been there for so long, and with this cyst he has survived, and it is very quite normal and quite it's normal that he would survive with the same number of cysts in the next few decades, so that he can have a near normal his natural lifespan with quite normal quality of life. So with that paradigm shift, I think we can still go ahead with this being a donor. But only thing bothering me is legally, because these are from one community, Muslim community, where apparently they will be very good, but something goes wrong, then they will not spare you. They'll go to any extent to bombard you. So only that, my worry is that only. If we will label it as ADPKD and still we considering all whatever ethics we have talked about now, discussed about now, so that if you can, I was just trying to convince my own faculty that if you can convince me that, probably, we will go ahead. So these are and in fact, one more thing which Vijay has missed, that is he has discussed about all the KDF guidelines and then the American Society guidelines. There's one European guidelines which says MRI criteria, patient with a high risk. This is a high risk because there's a strong family history. High risk MRI between the age of 45 to 50, 60. Cyst, MRI more than 6 cysts is diagnosed to have ADPKD. So even if we take that definition, he fits into the diagnosis of ADPKD. Irrespective of
is this cumulative or single kidney, madam? Is this cyst in a single kidney or cumulative?
Yeah, both kidneys. Like each kidney.
Cumulative. Each kidney, 6 cysts.
Each kidney. Madam, basically at 44, if somebody has ADPKD, it will definitely show in the ultrasound. There is no cyst at all in the ultrasound. That is little surprising. MRI does and shows or CT picks up more cyst nowadays because we are going for higher imaging. And then we have to redefine that. Normally 10 per kidney is considered to be, PKD. This person doesn't have ultrasound finding of any cyst, and there are 4, 5 in each side or one side. Still, I will have doubt. If you are going for a transplant, I think all this should be explained to him, and it has to be recorded. Then you can go ahead for transplant with the consent.
Dr. Sakthi?
First of all, I thank Peculiar Transplant Group for giving me this opportunity, but cracking a very difficult case in the first panel itself. So I just appreciate the Vijay Chander for presenting a nice case. I have one doubt. So whether they have done the genetic testing for the donor's father, so in which he has also multiple cysts. Because
donor's father genetic testing is awaited, sir. We have sent a test, but it takes almost 28 days roughly. Yeah. So I didn't yet know the report. I
just want to start my discussion from there. So so now for the donor, there is an unknown mutation in the PKD1 gene that has no relevance to, so far it has not been documented as pathogenic. Suppose if the father has the same gene mutation there and he had cyst, it is most conclusive that he might have ADPKD. So then we can definitely say that he has ADPKD. And the second part is, so you said that his occupation is goldsmith, whether he's a traditional goldsmith or who works in the fire.
He hasn't, I mean, actually they are their employee, they don't work, they are not the workers actually, they own the shop.
No. They are the owners. They have a very good chain of these goldsmiths across.
What I thought was somebody who's in the heat stress for a longer time. Could it be due to a repetitive ischemic injury leading to benign cyst developing due to chronic injuries. So that was my thought process actually. So coming to, suppose if it is a non-pathogenic, see, another important point apart from the cyst is the GFR. So if the total GFR is 115, it sounds bit higher for this at this age. For usually we work donors, so it will be somewhere between some 100, around 100. So are the kidneys really hyperfiltrating? So that is another area of concern for me. So if the kidney is already hyperfiltrating, it is not wise to take a kidney out of it. So definitely there is a higher chance of going up for ESRD. Otherwise, if it is a documented, if you do a genetic testing, the same mutation is found in his father, donor's father, then also it's not acceptable to go ahead. So that is my concern. Second thing is, if it is going to be, suppose if we are ruling out an ADPKD, it could be a simple cyst, then we can consider, see, if we search the literature, they say that even in the benign cyst, if the cyst develops more than 3 to 4 and less than 50 years, it implies that the kidney has suffered so many injuries in the early part of life, just because less than somewhere before 2 to 3 decades itself. So more the number of cysts, more the insult to the kidneys. That's what the recent it's no more seen as a benign cyst. So it's a reparative process. So that is the one. So in this reparative process, if the patient has a multiple cyst, it implies that the patient has so much of ischemic injuries in his early part of life. So if we think that it is a simple cyst and it is not related to ADPKD, after confirming his father's genetic analysis, we can go for a kidney biopsy to see how the other glomeruli are. If there is evidence of any glomerular sclerosis or evidence of glomerular hypertrophy, then we can drop him as a donor.
Very interesting points you have shown, actually.
In fact, there is one article. Yes.
Yeah, madam. Go ahead, madam.
Yes. In fact, there is an article which says simple cysts, are they really simple?
Yeah.
Okay, so as Dr. Sakthirajan has explained, so these represent some injury, kidney injury, and reparative process, and there is a fibrosis around the cyst. And on biopsy, these glomeruli are found to have more of a sclerosis than a the kidney without any cyst. So these, and they have shown that even the graft outcomes, long-term graft outcomes, are not similar to a donor without any cyst. So we have to take with a caution, even if it is a simple cyst, it's not an ADPKD. But as I said, so even even the simple cyst we have to take with the caution. But the ADPKD donor, we can consider deceased donor. But it is alive, definitely we have to think before we can take. And here doctor, I don't know whether we have you could appreciate that Vijay has talked about the bi-LL. So probably sometimes it's a double hit hypothesis. It's not mere presence of the genetic defect would not penetrate and then phenotypically and can present as a ADPKD. So there might be a bi-LL. So there are two genetic defects. So which might influence and depends upon which is more penetrating and then phenotypically presenting. So we have to also look at that angle. So even if the donor's father is positive, we might think that it is probably a less penetrating. And there's another concept. Even I'm not totally aware of that. There's something like a mosaicism, depends upon how many the alleles. It contains that the genetic defect. When they penetrate, basically I'm talking about the penetration. So it all depends upon that. So it is not as simple as we think. There are a lot of complexity, particularly with respect to the multiple mutations, and that's the reason why we find there's so much of different clinical presentation, right? From advanced. Now we are seeing more of patients. At an early age. Now we have very strong families of ADPKD, where we are seeing kids at the age of 15 to 19 to 20 years itself presenting, coming with a cyst. So the literature says that usually they are unusual that they present before 30 years. And once they crosses 30, 40 years, it's very unusual that when they don't have a cyst, they usually present with a cyst, and it's unlikely that ADPKD will not have cyst. So now we are seeing presentation beyond that, clinical typical cases being described in the literature. So there's definitely a possibility, but my opinion is looking at the donor himself as a, in isolation, how he has been behaving. So I feel it is unlikely that he is progressive to ESRD. If we can convince him, still we can proceed.
Thank you. So the jury is divided here. Actually, Deepak Ray sir is willing for a renal donation in this patient. The other two panelists are skeptical about the donation. And another point is legal points, as you told that there is some legal issues, and I don't know how to counteract with these legal issues when suddenly a thing crop up like this mutation has been attributed to the ADPKD and still we remove the kidney donor. In fact, in future suffering from a disease, we can attribute this. So you have European guidelines have shown that there is more than 6 cysts in each kidney. You can consider this as an ADPKD. But still now, other criteria, other society guidelines, which show that less than 40 years, and the guidelines are clear for age less than 40 years. Can we extrapolate that to 47 years? That is more than 40 years. So comparing that criteria with this donor, that is 47 years, still he can be acceptable for renal donation. According to your AST and your KD-GO 17. And more than 40 years, and we can still extrapolate this data for more than 40 years, and can we take this as a donor? And I don't know how to go about this case. And is there any study, madam, in India which has looked into the consequences of donation after renal cyst, simple cyst or complex, whatever thing? So are there any studies you come across to look into the fate of the donor or recipient who have received the cyst?
Yeah, from India, I didn't find any of the studies. So in fact, before presenting, we were looking at the literature. So whatever literature, limited literature we found was only, the Western literature. And with respect to, the definitions is all clear. So whether it's in American society or with KDIACO, the definitions as per the, the age criteria, the imageology, age specific imageology is clear. So 47, I think even if it is 47, this is not more than 10. So that we can extrapolate to 40, whatever 40, we can extrapolate 40 because this is not satisfying. It is even less than even the age. So I think we can, the age specific, the imageology, not the ultrasound, even the MRI also, I think we can still go ahead. So the Western literature, whatever I found out is with respect to ADPKD donor and simple cyst, we had a series of even Vijay has showed 16. So far in the literature, we have only simple multiple cysts, not in the simple multiple cysts, single or multiple cysts. They have a case series of 16. And they have shown that the outcomes are as similar as the donor without any kidneys. So this only the literature, published literature I could find. None from India. I think with this experience, we only have to start publishing this. And in fact, after this, I was just going through our own the deceased donor registry. So we have everything documented. So we could find out 10. So whatever the 6 patients which Vijay has not presented, they were all simple cysts with one random 1 or 2 cysts. And in fact, one cyst I remember which we have taken from MIMS hospital, and we have done deroofing during the on bench dissection, and we have taken there was one big cyst which was very superficial. So exophytic cyst, we have done deroofing and we have taken. So simple cysts we are all taken. So multiple bilateral with enlarged kidney. In fact, one of the patient had a liver cyst also. Though these patients never had a history of ADPKD and there was no family history of ADPKD. So this being multiple cysts with a liver and the presentation, even the cause of the brain death, if you can see, only one patient had road-traffic accident. Other 3 patients had a IC bleed. Probably it could be a, the complication of aneurysmal bleed. So these patients, and in fact, we have a policy of doing all the biopsies to payment the kidneys which have been discarded. So I was just trying to look at, even if it's a cyst, let us see what is the, the biopsy report. So surprisingly, if you can see, 2 patients, despite having a biopsy, there was no chronicity changes. Only one patient has chronicity changes. The other 2 patients where the biopsy was done, they didn't reveal any, the glomerular sclerosis or the IFTA. So with this gives a confidence that we can still use. So after this, I think we should have a policy of using the ADPKD. And I was just going through the literature, which ADPKD disease donor we can use. So there are again a guidelines, because the published literature source, the age group of 21 was 26 and other was some around 30, 35. The younger the age group, never the history of ADPKD. They presented with the IC bleed because of the aneurysmal bleed. And the creatinine is normal, within normal limits, and kidney sizes of less than 15 centimeters. These can be well accepted. And the recipient should be elderly, where the expected survival is not more than 10 years. So these two recipients, like where ADPKD was transplanted, one of the recipient was 75 years and the other recipient was 65 years. So these can be taken to recipients who are elderly. And in fact, one of the patient had so many issues and they are repeatedly being admitted to the hospital. So they took a chance and they have taken this kidney after informed consent. And in fact, I was looking at the survival rate. They got transplanted somewhere in 2019, and now patient is, it was published in 2022. So I think 3 years survival rate was good, and graft function was normal. So we have both.
Thank you. So
ADPKD donor as well as in a disease donor, and a simple cyst with the family history, when to take and when to reject.
coming to this case, what is your next thought after this presentation, after our discussions, what you are going to do for this case?
No, personally, I feel, because we have been interacting with the donor, so he said he has to give at any cost, and he has seen that all his the recipient family, most of the they had three patients being affected, the two sisters and the mother, all of them died. So he was very much interested in donating the kidney, and then it was only MRI shows 3 cysts in each kidney. All the three are subcentimetric. I think I personally feel that we should give informed consent, take the informed consent and explain all the risks, and then we should go ahead. So, but
are you going to do the biopsy, madam? Are you going to do a biopsy of the donor?
No, I don't want to. The more we investigate, we're trying to complicate the issue. So I don't want to biopsy. Okay. And we'll just wait for the, because anyhow we have already sent the donors, father's sample for
fathers.
So we will look at that if it is negative, and even if it is showing the other mutation positive, because father doesn't. This is a grandfather who has this, not the father. So so father knows this. Even if positive, negative, if patient donor is convinced, I think I will proceed. And I have to, only my challenge is I have to convince my junior colleague.
Okay.
You are right.
Yes.
For some remote chance of having some problem, and the husband should not be denied a donation, he will have psychological problem. All those issues, social issues, psychological issues, need to be also thought of.
Super. Dr. Ilangovan?
Yeah, so my final
what is your consensus?
So consensus, this is ADPKD, there's no doubt about it, because all these guidelines apply to random, unselected people who have cysts, but here we have a very high pretest for possibility, and the likelihood ratio is very high that this is ADPKD. So, and second thing is
suppose if your grandfather's mutation analysis is non-significant, still you consider this as an ADPKD?
No, we are not even seeing genetic test. There is only based on the probabilities. Next is like these readouts, like the genetic test readouts, I think has been handled in 2 different labs. And from going by what the quality of the genetic testing readouts we have, and also quality control, like I would suggest, if it was done in 2 different labs, these PKD1 and genes, they need to, I think, share with a common one person, and they need to come to know a consensus as to what is there in the recipient and what is there in the donor, if it was done in different labs. And third is like I would still go ahead and do transplant, explaining completely the risks and benefit and the option sets are available. And I think informed consent is taken legally. I think we are all protected. Like if for Vijay is worried about hyperfiltration and secondary FSGS and injury, but I think as Dr. Swarnalatha pointed out, having the patient lived till 50 with no injury, with no GFR decline, I think he's likely to live another 20 years plus with working kidney. So if the readouts are done on 2 different labs, I would suggest that that both of them share the information and come. Probably it could be the same gene. Actually, it could be just a. We are not even considering the error of judgment error of the genetic analysis.
Thank you, Dr. Sakthirajan.
Yeah, if the grandfather's genetics show the same mutation, I will not go ahead. So it's skeptical going ahead because it's a proven ADPKD. Then with the GFR of 115, the age of 47, I won't go ahead. But if it is different, it is not. It is a very simple cyst. Then we can consider going because the recent case series, retrospective case series published in Clinical Transplantation in January 24. It says that they have analyzed more than 100 patients. So they say even in the presence of 3 cysts, there is no big difference between the graft outcome, as well as there is no big change in the for the donor also. Even the kidney with the cyst in the donor, if we lift, it will have a catch-up GFR similar to the normal donor. So it is the biggest series so far published now. So by this, if it is a simple cyst, we can go ahead. But if it is going to be a genetically proven ADPKD, I won't.
Okay, Dr. S.Vel Arvind.
The final
Ma'am,
comment.
you win. Ma'am, you win. 2 out of 3 jury voted for you.
Yeah, yeah.
So we can take the audience poll also in the end, I believe.
Yeah, I'm searching the chat box actually. There is no questions or comments.
I'll go with the transplant.
Dr. Wayne.
I'll go with the transplant. As you said, I'll go for a biopsy. Madam said, okay, I'll go with the biopsy. I'll go with the transplant for this patient. So looking into all the quality of life, everything, I think this is the best option too. He's motivated, and so I think I'll go with the transplant. It's
regarding Dr. Sakthirajan, interesting comment on hyperfiltrating kidneys. Actually, how common you are seeing around GFR more than 110 in 40, 45 years. We do see GFR more than 100 even in 60, 70 years with normal kidneys and all. But what significance we'll give for this patient, we don't know. Any consensus with the panelists? He is concerned more with whether the kidney is hyperfiltrating, the cystic kidneys hyperfiltrating that will eventually lead to second FSGS in other kidney. So is that valid?
We see more than 100 the GFRs, and different nuclear medicine department will give different GFR.
Yeah,
that's very true.
So it was an interesting one actually. Fine. So with no other further questions, we don't have any other relevant questions in the chat box. So the consensus here is to go ahead with the transplant by the 2 panelists, and the third panelist is skeptical about doing the transplant, provided the genetic testing is positive negative. So the jury still is out. So madam, you just please update us on the grandfather's genetic profile. And if you do the transplant, you just keep us update on the cases. So yeah, sure. It was an interesting meet. It was an interesting meeting, and given a lot of insights, a lot of deliberations regarding how to deal with the polycystic kidneys. And thank you very much, Swarnalatha madam, for wonderful case, brought in a wonderful case and wonderful discussion. And I would like to thank the panelists, Dr. D.S. Ray, Dr. Ilangovan Veerappan, and Dr. Sakthirajan for giving the valid insights and making the discussion fruitful and eventful. And that's on the Saturday evening. And I thank the dear delegates who have attended this meeting, who have given a lot of support to us all these days. And we have a YouTube channel also regarding peculiar case series. You can see the recordings of the previous meetings. There is a link is given in the chat box, and even we have posted in the group also. You can see the previous recordings also. And we encourage our institutions to present cases regularly so that we can learn from each other this for this transplant Pantora. And I thank the MQ team for the support they are given. And thank you one and all for attending this meet. Thank you very much.
Thank you.
Thank you for the opportunity. And everything goes on well. Probably after 6 months or 1 year, we'll try to present the outcomes of this patient in the same platform.
Thank you.
Thank you for the opportunity, sir.
Thank you. Thank you. Thank you.
Thank you, sir. Good night.
Thank you.